In this presentation, I'm going to talk a little bit about the clinical assessment of low back pain. So if you do experience low back pain, you should probably have an assessment with your doctor or healthcare professional, and questions you will be asked include the following. So it might be useful to note what your answers would be to these questions. So your doctor or healthcare professional is going to want to know when your pain started. Did it come on suddenly or gradually? Over the time you have been experiencing the pain, have there been any fluctuations in it? Is there anything in particular that relieves the pain or makes it worse? Are you taking pain medications, and if so, which ones are you taking? Are you sleeping okay with it, or is it worse at night? Was there any particular event that you think might have triggered the pain? Is this your first time experiencing the pain? Do you have any other symptoms such as trouble with your bowel or bladder? Does the pain go down either leg or both legs? Are you having numbness or tingling? Are you having any weakness in your legs along with the pain? And does the pain come on with walking and get relieved by sitting or resting? Or does it come on when you are sitting and get relieved when you are standing? So these are all useful pieces of information to help your healthcare professional to begin to formulate where they think the pain might be coming from. The next thing that will be established is whether or not you have a past medical history. So, for example, if you have something like osteoporosis or osteopenia, then it would be really important for your doctor to know this, because you do have a greater chance of a fracture. Or if you've been treated with immunosuppression for any reason, if you have a history of diabetes or obesity, if you're taking any other regular medications, is there a strong family history of low back pain, because there can be a genetic component? And have you had similar episodes of this in the past? The next step of your clinical assessment will be your clinical examination. So the strength in your muscles will be checked and they'll be compared side to side. You'll have a sensory examination, and this means your doctor will test your ability to feel things like light touch and pinprick sensation. And this will be done in a pattern in your legs, what we call a dermatomal pattern. And that just means that the sensory nerves that are leaving the lower part of the spine are destined for certain patches of your leg in terms of the sensory sensation or the sensation. So it'll help your doctor to figure out at which level the low back pain might be coming from. You'll have your knee and your ankle reflexes checked. If these reflexes are very brisk, you may end up having a scan of all of your spine, but normally they're either normal or reduced, and your doctor will check this for you. You'll then have a plantar reflex checked, and this is where your doctor will take the end of a pen or something and just rub it lightly along the sole of your foot from the heel up to the toe, and see what way the big toe points. So it should point downwards, and that will be checked. And then you might have other specific tests that are designed to see if the pain comes on, one of which is called the straight leg test. So you'll be lying flat, your leg will be lifted up, and your doctor will be checking things like whether or not this brings on the pain that you've been describing. And if you suffer from low back pain, you might have experience of having this clinical test done. So this is just to show what I mean by the dermatomal pattern. So again, each area of the skin on your legs represents a level within the spinal cord. So if you, for example, have numbness in your little toe and the outer part of your foot that's brought on by activity, that may signify that you might have a minor compression at the S1 nerve root. So that's why that part of the examination is done, and that is what is meant by a dermatomal pattern. When taking the history and doing the clinical examination, it will be important to identify whether or not you have any red flags. So red flags are just particular symptoms in the history or signs on the clinical examination that would imply there is a more serious underlying cause for your pain. So, for example, red flags in a medical history might be things like having a history of cancer, having ongoing treatment with immunosuppression, having a history of osteoporosis, having a recent onset of trouble with the bowel or bladder function. So that could be either incontinence or an inability to pass water, or to have a bowel movement, or having an abnormal or reduced sensation when you're wiping after going to the toilet, or if you have new onset of pain that goes down both legs, what we call a bilateral radiculopathy, or a new onset of weakness. And then red flags in the clinical examination might be things like very brisk reflexes or absent reflexes, if there's a clinical weakness on the examination, or if the pain is so severe that you can't be examined, that might also be considered a red flag. In more recent times, we've begun to understand the complex nature of pain and the fact that pain is more than just the activation of pain pathways, and there is a lot of pain that can be generated within the brain itself. So what has been described as yellow flags refer to aspects that someone might be experiencing that are not necessarily related to the low back pain itself, but that might be making the pain worse. And it has been demonstrated that if these kinds of concerns are raised by patients and they are dealt with, that it can have a really positive impact upon the future experience of pain. So examples of yellow flags would be something like a belief that pain will never go away and that any movement will make it worse, a fear that you won't be able to resume normal activities, that there will be an impact upon the ability to do recreational activities or even job-related activities, so there can be financial stress associated with it, believing that you will never have control over your pain, or believing that a scan is absolutely necessary and will, in order to move the management forward, and will give the answer. It's really important to also think about what your expectations are, because it is not uncommon if you are experiencing pain and that you visit your doctor for a consultation to then have the expectation that a scan should be done and that it will give the reason for the pain, and what will follow on from there will be treatment and resolution of the pain. And this actually isn't usually the reality, because firstly, if your clinical examination doesn't show any of those red flags that I described on prior slides, so you don't have any weakness or abnormal reflexes and your history is okay, then a scan actually isn't really indicated. It hasn't been shown to have any particular benefit in this clinical scenario, and you will likely be treated with physical exercise and pain medications if you need them. Even if the MRI scan does show some changes, especially some degenerative disc disease, it may be felt that the pain you are experiencing is more severe than what are the changes on the scan. And so again, it may be felt that the symptoms such as the pain do not necessarily match what is on the scan. And even if the MRI does show some minor degenerative changes in your back, it doesn't usually have a particular treatment plan or option. You won't necessarily have surgery or injections if you have some degenerative disc disease in your back. So it is important that you have this kind of discussion with your doctor about what you expect to happen. And in this way, your management plan can be discussed and agreed upon. And so if your doctor feels like you don't really have a huge amount of changes on your clinical examination or anything particular concerning in your clinical history, it might be deemed that you should have a trial of some type of physical activity or a pain medication, and then wait a number of months and see at that point if a scan would be worthwhile. So by taking everything into account, so that being the history, the physical examination, the presence of red flags, the presence of yellow flags, and importantly, what your expectations are, then a management plan can be formulated. So then your doctor is trying to decide things like, is your pain mainly nociceptive, neuropathic, or nociplastic? And in the presentation on the low back pain with facts and on the presentation on causes of low back pain, I explained in a bit more detail what the different types of pain are. Nociceptive being the activation of pain pathways from things like mechanical stress, neuropathic being pain That's more caused by compression of nerve roots in the back, and then nociplastic pain is the amplification of pain signals within the brain that has been described in more recent years. So by characterizing this for you, it'll give your doctor or healthcare professional an idea of the likely generator of your pain. So for example, if pain is very widespread and you have difficulty localizing it other than the low back, and there's generalized hypersensitivity to usually non-painful stimuli, so if your back just kind of touches off something, or simple movements that shouldn't elicit pain cause pain, or you have other symptoms such as fatigue and poor sleep in association with the pain, you might have a greater nociplastic component to your pain. But if your pain is more brought on by mechanical stresses like lifting or standing for a prolonged time, then you might have a more nociceptive type of pain. And then if you have pain that shoots down your leg or is associated with numbness or tingling, that might be more likely to be the neuropathic type of pain. So based on all of this information that your doctor has gathered, and they'll begin to formulate a management plan, they'll be trying to decide things like where is your pain localized to, whether or not you need a scan. If you need a scan, is it an urgent or a non-urgent scan? Do you need pain medication? Is any rest advised? If you are going to be advised to exercise or stretch, what should you be doing? Do you need referral to a physiotherapist for some exercise advice? And what is your follow-up plan? So if following the diagnostic evaluation, your doctor feels that you do have nerve root compression, then this will be referred to as a radicular pain or radicular syndrome. And in this scenario, you probably will be sent for an MRI of your lower back. This only forms part of your management. The treatment of your symptoms will largely be comprised of exercise and pain medication if you need it. But in this case, the scan is important, but it isn't urgent. And it is also important to understand that it may not imply that you need surgery. If following the diagnostic evaluation, your doctor feels you have what is called spinal compression or cauda equina syndrome, so this refers to the very end of the spinal cord, is called the cauda equina, and it's where all your nerve roots fan out, and it looks like a horse's hair, which is why it's called the cauda equina. And if there is compression at this level, then this would be deemed an urgent scan. And you don't really have to worry, because if anybody is sent to the emergency department with a query of a cauda equina syndrome, their scan is done as an emergency. And then following the scan, if it turns out you don't have cauda equina syndrome, then your management will form more part of the physical activity, the pain medication, and that type of thing. If following your diagnostic evaluation, it's felt that you may have spinal stenosis, you will again need a scan, and this is considered semi-urgent. So spinal stenosis doesn't necessarily imply that the spinal cord itself is compressed. It can be that the spinal canal, so the canal that the spinal cord runs through, might be very narrowed, so that you are more at risk of either your spinal cord or those nerve roots being significantly compressed. Then you will also need a scan, and again it'll be a semi-urgent scan. And following the scan, if it doesn't show that there is significant spinal stenosis, then you can engage in more the kind of physical activity and the medication and that kind of a program. If you are experiencing low back pain that doesn't meet any of the criteria that I just described on the prior slide, then you mightn't even need to have an MRI scan, or you can most certainly defer your MRI scan for a number of months and try some other kind of management. This is because even when changes are found on the MRI scan, it does not automatically mean that it is the cause of all of your pain. So patients with low back pain will be familiar with being told that there's wear and tear on the back, but not in keeping with their level of pain. And it is now, because we have a much greater understanding of pain mechanisms, that we can understand that pain is more complex than just the initial inciting event or the mechanical changes in the back. And like I have explained on the presentation on low back pain, some facts, we now look at treating patients through the biopsychosocial lens, which means we are treating the whole patient and not just the localized low back area where the pain is seeming to be coming from. So the mainstay of the management of what is then referred to as non-specific low back pain is things like patient education. So this presentation series that I'm doing is an example of that. Physical activity, pain medication, ideally in the shorter term, and forming a management plan with your doctor or healthcare professional that you understand and you are comfortable with, and having a form of kind of re-looking at the management plan if it's not working for you, and seeing if at that stage there needs to be any change in what you're doing, be that in terms of the physical activity or in the activities that you do day to day, and whether or not some imaging would be worthwhile. So to conclude, if you have low back pain, having a clinical assessment is really important. It is also a good idea to try to gain an understanding of the likely outcome of the process, because this will really help with your management. Being involved in your management plan and having a clear understanding of what this plan is will likely help your pain. If any of what you've been told is confusing, you should think about having a follow-up assessment if you can. If you really feel that you need a scan and you feel like your pain will not get any better until you have a scan, then you should have a chat with your doctor about this. Physical activity is going to form a big part of your management, but it's worthwhile spending some time figuring out what kind of physical activity works for you. And in another presentation, I'm going to talk about management of low back pain. Thanks.